liaison psychiatrist, and he chairs the Public Health Wales National Service Group for Liaison Psychiatry, and he is going to talk about inequalities related to mental health.
Thank you. First of all, thank you to the organizers for asking me to come and talk. It was quite a tough ask because there's a cricket match going on, final India versus South Africa. Anyways, if anyone is looking for scores, India is 70-3 in 10 overs roughly. Does anyone know, I hope everyone knows what liaison psychiatry is. Anyone who doesn't know liaison psychiatry, what liaison psychiatry means? So quite a few people. First of all, it's good to see a number of people quite familiar, because as a liaison psychiatrist, my job is working in general hospital setting. I'm a psychiatrist, but I work with colleagues who deal with physical issues, and I try and help them with mental health issues. So that's liaison psychiatry in a nutshell. It's one of the oldest branches of psychiatry. Apologies that if I start coughing, I've just come back from Saudi Arabia and I've post-viral cough. Disclaimer, I'm going to talk as a liaison psychiatrist, not as a psychiatrist from an ethnic minority. I've been a consultant in liaison psychiatry for almost 18 years now, and hence I like to think that I'm doing this job because, number one, I enjoy it. Number two, there's a lot of inequality between, as Raja said, inequity between physical and mental health. Thank you to the speakers before me. They have identified this, and I'm not going to spend time talking about it. Health is not equally distributed. Mental health, even so. Big problem. I'm going to ask you some questions. First of all, how many of you work with mental health related issues? Okay. All right, okay. Not many. Now, let me ask you another question. I'm going to try and learn from you, and hopefully slides that I'm going to share, they're going to be a learning for me. They have been a learning for me as I was preparing for this talk. But question number one, how frequently do you explore your patient's everyday experience of mental health concerns? Always, not as often as I would like to think that I do, as often as I can, but takes a lot of time. Almost never. My patients don't want to talk about it. You don't have to put your hands up, just register this somewhere, and we'll perhaps come back to this. Second question, how frequently do you explore your patient's illness beliefs? Again, the same set of questions. Question number three, how frequently do you explore patients' ideas, concerns, and expectations about treatment? Just register these questions and your answers. Okay, those of you who put your hands up, actually, everyone in the room, if you're in a health profession, this is the answer. All of you work with mental health. There's no health without mental health. And that's the slogan that I've been using for many, many years as a psychiatrist. When I was working with, some of you might know Professor Jonathan Bisson, my mentor and my trainer. And this is something I learned from him many, many years ago as a junior doctor. And that drove me to come into liaison psychiatry. And then I read this paper in 2001, editorial saying, not only is the distinction between mental and physical illness ill-founded and incompatible with contemporary understanding of the disease, it is also damaging. And it ends by saying, this division is archaic and deeply misleading. So if I stop here, I think I've done my job, but just to illustrate further, how many of you know about parity of esteem? So parity of esteem is something that drew me into liaison psychiatry. So this is a paper in 2009, but even before that, I had read about this, that only 32% of those who reported recent symptoms consistent with common mental disorders received treatment, only 32%. Now let's compare that with cardiology. Okay, 78% people with heart diseases, 91% with high blood pressure receive treatment. So there's a big difference. There's a big gap. So Raja's title could have been my title: Mind the Gap, Bridge the Gap. Thanks to the previous speakers who've talked about socioeconomic position, gender, sexual orientation, ethnicity, and that's, oops, sorry, wrong button. That's okay. It doesn't matter. It's okay. It's okay. So Public Health England, they have produced these wonderful sets of slides and information which I've posted from their website and I'm sharing with you. People with severe mental illness are also more likely to live in less safe neighborhoods. They have less access to healthy foods and fewer opportunities to be involved in healthy activities. Simply, employment. People with mental health problems are more unemployed or are in employment which is not up to mark. Benefits, 61%, I think, 51% almost are on employment support allowance. Social isolation, housing issues, deprivation. People with mental illnesses seek more help from Citizens Advice Bureau. But this is such a telling figure, and that takes me on to the next bit, which would be about the parity of esteem. Third of all cigarettes are smoked by people with mental health problems. I'm not going to talk about vaping. I've got a big beef about vaping. Vaping is a big no-no. And if you go onto anywhere on a high street, you would see these unregulated vaping shops. Kids in school carrying vapes. We don't know what's going to have a long-term effect of that. And that then makes me think about this, and I'm glad to see my friend Ali, who's a diabetologist, and he would sometimes, once or twice, he's sent me, Tayyab, you need to see this patient, Mohammed. You have said this to me, Tayyab, you need to see this patient, and he's very psychologically minded. I'm so grateful to have colleagues like him in UHW. But people who have mental illnesses, serious mental illnesses, they are more likely to have physical health problems across the domain, not just one or two, but across the domain. And if I knew that Mohammed is going to be here, hence I put diabetes, but if I took diabetes out and put any other physical health problem and put this algorithm like this, the link between physical health and mental health. These are lifestyle barriers, lifestyle choices, lifestyle issues that can affect people. You'll get this, if you want, I can send a handout to me and it can be circulated. Younger adults, excuse me, younger adults between 15 and 34, 3 times higher mortality rate. So there's a big inequality for physical and mental health, and people with mental illness, they're more likely to develop physical health issues. How many liaison psychiatrists do you think we have in University Hospital of Wales? Any idea? Well, Dr. Shetty is not allowed to answer because he knows. It's me for general adult up to the age of 65, and then there's one who deals with over the age of 65. And we are, how many should be? We should be at least four of us. And people with mental illnesses, they have a high mortality rate, much above the general population. And this is the figure that really annoys me. The mortality rate is not coming down. The graphs are not going down. And these are cancer, cardiovascular, respiratory, liver diseases. The graphs are not coming down. More closer to home, Wales. This is from NHS Confederation. This is what they have said on their website. Third of our kids are living in poverty in Wales. I did say I won't be talking as an ethnic minority, but perhaps something might come up later in the talk about ethnic minority as well. In Wales, most deprived neighbourhoods, mental health, people with mental illnesses living in most deprived neighbourhoods. Benefits, huge issue. But this is something important for general practitioners and everyone who deals with long-term conditions. Approximately 30% of people with long-term physical health conditions also have mental health problems, and most commonly depression and anxiety. I tend to see people being put on antidepressant medications, and then my job is at times taking them off antidepressants and finding the right medication or the right treatment. So there was this biopsychocultural term given, and we'll come to that in a minute. But this is such a telling figure for Wales. Only 1 in 3 people who experience mental health problems are able to access treatment for their mental health problems. And there are barriers for that. And those of you who know about mental health, you would also know about suicide. This is 1-year data. 356 patients, above the rate in England. Mostly men. Highest between 35 and 44. And most deprived and next most deprived, high rates, but statistically significant from those who are least deprived. Unemployment, forensic history, all related to suicide. This is the data for England. If you see, again, the graph is linear. It's not coming down. And the rates in England are lower than Wales. So ethnic minorities, inequalities, 2022 paper. And this is with people from diverse ethnic backgrounds. They all had some similar negative perceptions, experiences of the services for mental health when they needed help. They all perceived a biomedical rather than a biopsycho social or psychocultural, and they thought of this as white colonial epistemology. These are not my words. These are from that paper. They thought that assessments were reductionist, oppressive, and racist. Inability to consider the whole person and the lived experience of ethnic minorities. You mentioned those from the perimenopausal time. Lack of awareness. Now, I can spend another half an hour just talking about spirituality and religion. Things that as a Muslim, I would consider as preoccupation, not delusional. Many others would consider it delusional, and hence people could be put on under this section of Mental Health Act. And then lack of awareness related to racism, migration, especially refugees, and I'm glad that Ahmed, you're going to talk about refugees and some of the work we know and share. And social marginalization and the community interdependence. Those factors are not considered. And when I was coming back from West Wales, I looked at this and I thought, this is either me, the little red car, as a liaison psychiatrist in a busy general hospital. But then I thought, no, if I'm feeling like that, what about a patient? How would a patient feel like with so many barriers, so many obstacles? I'm very fortunate. I can pick up phone and call some of my colleagues and say, there's a patient I've seen, you might need to see this person, please make a priority. Or my colleagues would call me and say, Tayyab, could you please help out? But then that shouldn't be a case of me being an Asian practicing psychiatrist. It should be for everyone to be able to deal with those problems. So what are the barriers? Complexity of problems, lack of understanding, choosing not to tell. And there are certain things about stigma, and we'll talk about stigma. Because of the pressure of time, I'll skip this slide. But there are a number of barriers. And we have done some work in the pain clinic. People who know Sharmila Khote, with her, we did some work. And what patients want: collaboration, consistency, and empowerment. That's what they want. Now, the Royal College of Psychiatrists has done this work around psychiatrists, but I think this is something which applies to everyone. Doctors and psychiatrists, we have different roles. We have a role as a doctor, but we also have a role as a leader in the team. We got to be transparent with our patients, but important to think of lived experiences. There was a question around data. When there's lack of data, you need to think of the lived experiences and examples on qualitative information. And what are those things? By doing that, by diversifying yourself into these different roles, you build trust with patients. You have to be empathic towards patients. You need to have good communication skills. Not looking at this screen here, investigation, and patient is sitting there, not talking to that patient. So those tiny little things, and developing that respect and dignity for people with mental health problems. And we can spend another half an hour just talking about this slide. It's wonderful work done by a lot of people, and credit goes to them that they have talked about those many, many little things. This would be in your handout if you want. But this thing, challenging stigma, is very important. So stigma could be is a process where human differences are labeled and attached to negative stereotypes. And stigma has got different levels: structural stigma, interpersonal stigma, and intrapersonal stigma. This is a wonderful paper in 2022 by Smith et al., which talks about stigma. And structural stigma, in a nutshell, the environment we work in, underfunding towards mental health services, underfunding to implement policies. There are policies. It's not that there are no policies. There are policies, but how to implement those policies and changing practices and models of care. Again, policies, 20 documents published between 1999 and 2020. They talk about ethnic inequalities, differential access, differential treatment, differential outcomes, based on people's experiences. Coercive treatment, i.e. Mental Health Act, detention, black young men likely to be detained under Mental Health Act, lack of understanding. And then interpersonal stereotypes. All of us have stereotypes. Okay. I'll be politically incorrect, but here we go. Okay. Muslim women are oppressed. I've just been to Saudi Arabia, and I've seen that women who were within our group, they had more chance to go and pray closer to the Holy Kaaba than men. Women have mothers have a very respectful position in Islam. But women could be oppressed in any society, not just Muslim women. So it's very important to change those stereotypes and those thinking styles. Negative attitudes. Myrtle was here. I could have asked her about negative attitudes around. She's negative attitudes. Myrtle, you can help me out if I'm stuck. Bad behavior. All bad behavior is related to psychiatric disorders. A number of times I get referrals for people who are behaving badly and labeled as psychotic, and they're not psychotic. Would you bear with me on that, Myrtle? And then, what else? Yeah. People with mental illnesses are dangerous. They kill more. It hurts me to see the news when there's a news item that someone with a psychiatric disorder has killed someone within the family or otherwise. They are less likely to kill than general population. Those are the stereotypes and stigmatizing practices we need to change. As doctors, low rates of recognition, that's a stereotype for not being able to recognize mental health problems or psychological problems. Now the intrapersonal. Okay, intrapersonal, When public stigma is internalized, I'm not going to seek help because it's going to affect my career. Very common in men. So I do a talk on, oh, by the way, doc. It's usually towards the end of their consultation when they would say, oh, by the way, my energy is not good, my sex drive is low, I'm feeling low in my mood, and the 7-8 minutes for the GP are over. So those are the things to consider. Inequalities, there are solutions to that, and we need to really think of those solutions. Achieving parity is my solution to it. I've done some work in Kenya and Karachi around dealing with stigma and having making ambassadors for mental health who are not health professionals. Those 3 questions that I asked you, I hope I've convinced you to explore everyday experiences, patients' illness beliefs, and ideas and concerns. If you were 3 or 4, I hope you've moved up to 1 or 2 after this talk. 7 Sins of Medicine, I love it. 1949, Richard Asher. If we can avoid those 7 sins of medicine, I think we can bridge the gap between physical and mental health.
Thank you very much. Please reserve your questions for later.